So this slide's presentation is an overview of prosthetic biomechanics, and it's also going to introduce you to some basic prosthetic adjustment terminology. What you see here is a lateral view of a transtibial prosthesis. Okay, this is considered a neutral socket because the socket here is directly over top of the pylon, which is directly over top of the foot. Okay, throughout the rest of the slides presentation, we're going to do various things with the socket and talk about how it's going to affect both the stability and mobility of the patient. But from here, you can see this is the heel of the foot, hence I've labeled this side posterior, and this is the toe of the prosthetic foot, so this is the anterior, anterior to the patient. Heel lever versus toe lever, this is going to be really important for understanding how these different changes are going to affect both stability and mobility for the prosthetic patient. First, this X represents the center of the socket. I've drawn a line right through the center, through the pylon, through the foot, and this new line represents the ground reaction force coming in from the heel. And this would be, say, initial contact in the gait cycle. What you should know is that the distance between the center of the socket and where this ground reaction force is coming up is known as the heel lever. Also, if you can imagine, for a prosthetic foot, you have the keel that comes down not all the way to the front of the toes, but almost to the front of the toes. Okay, this is the point where terminal stance would happen. So if you have a ground reaction force coming up here at terminal stance, this ground reaction force is here, and the distance between this force and the center of the socket is known as your toe lever. Most important thing to remember for the rest of the talk. Every time we decrease the size of the heel lever, we will increase the size of the toe lever, and this is going to promote patient stability. That means it's going to help to keep them in knee extension. However, anytime we increase the heel lever, which is here, and decrease the toe lever, you're going to increase patient mobility or knee flexion. For the rest of the talk, we're going to talk about different ways that we can change the size of the heel and the toe lever and how it affects the mobility and stability of the patient. Okay, prosthetic adjustment terminology. First, we're going to start out with angular adjustments. And by angular adjustments, you can see here from the picture that I've taken the socket and I've just rotated it. Rotated it backwards here. Okay, this is an angular adjustment. The other angular adjustment that I've made here is I've taken the foot and I've rotated it downward. This is an angular adjustment that is called plantar flexion. So if I take the socket and I rotate it backwards, that's called extending the socket or socket extension. And here I've just taken the foot and brought it into plantar flexion. And I've told you up here that both of these are going to promote stability. The reason why they both promote stability is they both decrease the size of the heel lever and increase the size of the toe lever. Let's take a look at how that happens. So the center of the socket is still here. However, the ground reaction force coming up here through the heel is now very, very close to that socket. So that results in a decreased heel lever. However, this toe lever is now increased because the socket is rotated backward. Same thing happens over here with the foot that's plantar flexed. Hopefully you can see that if you take this image here with the plantar flexed foot and you rotate it a little bit counterclockwise, that it looks a whole lot like the socket extension. You're just putting the foot up and rotating the socket backward. Both of these situations are going to place the ground reaction force anterior to the knee, promote stability, and it's really good for patients with weak quads. Next, another angular adjustment but this one is going to promote mobility or knee flexion. Okay, to promote knee flexion, you have the angular adjustment of socket flexion, and here you can see the socket is flexed forward. You can also have the angular adjustment of foot dorsiflexion, where here the foot is just brought up into dorsiflexion. Both are angular rotations. Both of these are going to increase the heel lever and decrease the toe lever. So if you look over here, ground reaction force coming up here at the heel, that is now got a longer distance between that ground reaction force and the center of the socket. However, the toe lever is shorter. And hopefully you can see that if you take this image for socket flexion and rotate it just a little bit counterclockwise, it looks a whole lot like the foot dorsiflexion. As I've said, both of these adjustments are going to promote mobility or knee flexion. Therefore, they're going to be better for patients with strong quads. Okay, now let's look at a linear adjustment. Okay, this is the first linear adjustment we've looked at. We've had the couple angular adjustments previously. This is a linear adjustment that's going to promote stability. Okay, what's happening here is the foot and the pylon are the same, but the socket has been moved backward, moved posteriorly. That means the center of the socket is right here, and hopefully you can see the ground reaction force coming up from the heel to the center is much shorter than the ground reaction force coming here has been increased. This will place the ground reaction force anterior to the knee, promoting stability, and it's good for patients with weak quads. So, placing the socket posterior is going to help promote stability. Another linear adjustment that you need to be aware of is a linear adjustment of having the socket placed more anteriorly. So the foot and the pylon are still in the same place, but the socket moves forward. Okay, this is going to result in an increased heel lever. So here your ground reaction force from your heel is a little bit longer, and a decreased toe lever. This places the ground reaction force coming up here posterior to the knee, promoting knee flexion, and it's going to be good for patients with strong quads. This is the big picture. I've taken this and I've tried to break it down into individual pieces, but if you understood the slides that I've just gone through, this should make a whole lot of sense. Overall, for transtibial prosthesis, if you decrease the heel lever and increase the toe lever, you're going to promote stability because you're placing the ground reaction force anterior to the knee, which promotes knee extension. A couple of the things that the prosthetist can do to make this happen. Okay, the first we talked about the socket extension. That's tilting the socket backward. That's representing by this arrow here. So imagine that socket tilted backwards. A linear change is going to be moving that socket posteriorly. And the other angular change that we talked about is having the foot plantar flex. So imagine this arrow here causing the foot to plantar flex. Additionally, you can have a softer heel cushion, particularly in those satch feet that we talked about previously. And this softer heel is going to help promote plantar flexion of the foot. All of these things are going to be really good for patients with weaker quads. Now on to the other side. If you increase the heel lever and decrease the toe lever, you're going to promote mobility or knee flexion. Okay, because you're placing the ground reaction force posterior to the knee. Things that the prosthetist can do to help with this are going to be to flex the socket. That would be represented by this arrow here, or if you can imagine the socket is flexing forward. The socket can be moved linearly, anteriorly on the foot. The foot can be dorsiflexed, this arrow here. Or if you have a stiffer cushion placed back here at the heel, then when the person goes into initial contact and loading response, they're not going to be able to go into that much plantar flexion. They're going to be stuck in that more dorsiflex position. All these things are going to promote knee flexion, and they're good for patients with stronger quads. Now, moving on to other prosthetic adjustment terminology. What you're seeing here, again, in the blue is the socket, the red is the pylon, and the green represents the foot. Only this time you're looking at an anterior view. Okay, so let's say this is an anterior view of the right lower extremity. Okay, and this would be considered a neutral socket, since the socket is aligned right over the pylon, is aligned right over the middle of the foot. Okay, if this is a right lower extremity, that makes this side medial and this side lateral to that right lower extremity. Linear adjustments that can be made. Okay, there's something known as a foot inset. Here's the socket, but the foot and the pylon have moved medially. This medial inset or medial change, this movement medially, is known as a foot inset. And you can imagine if this were the right lower extremity, the change that would happen with the ground reaction force on mid-stance. I mean, here the ground reaction force is going to be more medial to the knee, and that's going to mimic normal gait. Okay, prosthetists may choose to create a foot inset, not necessarily to enhance patient stability, so knee flexion or extension, because now we're thinking medial or lateral, right? What the prosthetist might use a right foot inset for is if the prosthetic itself were causing increased pressure in an area of the lower extremity or the residual limb that they didn't want increased pressure on. By bringing the foot and the pylon in, you're going to create more pressure medially than laterally. Similarly, if you bring the foot out, the foot and the pylon compared to the socket laterally, that's called a foot outset. Okay, again, this is a prosthetic adjustment that isn't going to affect knee stability as much as it's going to affect where the pressures are falling on the residual limb. And then finally, there's just two more angular adjustments that we need to talk about. Okay, the first is, if this is still your right lower extremity, this is considered an adducted socket. So what happened here is that the socket itself was just rotated laterally. Okay, this produces a varus alignment, and if you remember back from kinesiology, varus means that the distal end, here's the distal end of the socket, is more toward midline. So if this were the right lower extremity, the left lower extremity would be over here. That socket is pointing toward midline of the patient. And then finally, the last angular adjustment is going to be an abducted socket. Okay, what's happening here is that socket is rotated medially. This is called abduction or valgus alignment, because the distal end of the socket, which is here, is now pointing away from midline of the patient. Again, this is the right lower extremity, and here's the left lower extremity. So you can see that socket is pointing away. Valgus is pointing away from midline, the distal end.